Welcome back to the deep dive. Today we're making a bit of a shift, moving from the theoretical to some really practical knowledge that saves lives.
We are.
We're jumping into a full deep dive on basic life support, or BLS, and we're using this fantastic handbook that really boils down the 2015 AHA guidelines.
It's an excellent source. And, for anyone learning this or just refreshing med students, new nurses, even seasoned responders, this is just core content.
Right.
Our mission here is to really get at the science behind the steps, not just, rote memorization. And we can't forget why this matters so much. Cardiac arrest is still behind over 600,000 deaths a year in the U.S. alone.
A staggering number.
It is. And the difference between a good outcome and a tragedy,
Yeah.
it often just comes down to quick, confident, informed action in those first few minutes.
Absolutely. So to organize all this, we're going to build our conversation around two foundational pillars. First, the chain of survival.
Yeah.
And second, the nitty-gritty mechanics of what we actually mean by high-quality CPR.
So let's lay that groundwork. The fundamental goal of BLS is really just to buy time.
Buying time.
Exactly. You're trying to prevent or at least slow down the damage that a lack of oxygen does to the heart and critically to the brain until advanced care can take over. That clock is ticking, and it's unforgiving.
And when you talk about systems, you have to start with the chain of survival. You mentioned two of them, one for adults, one for kids. Why the split?
It comes down to the cause. For adults, cardiac arrest is almost always a primary heart problem, a sudden electrical failure, a mechanical issue.
So the heart itself is the origin.
Right, which is why the adult chain is all about speed. Recognize and activate EMS, start CPR early, defibrillate with an AED, then advance life support, and finally post-cardiac arrest care. Time is muscle and time is brain.
Okay, that makes sense. But for kids, it's different.
Completely different. For infants and children, cardiac arrest is usually secondary. It's the end result of a breathing problem that got progressively worse.
Like an asthma attack or choking?
Exactly. The lack of oxygen comes first, and that then causes the heart to fail. This is why the pediatric chain's very first and most important step is prevention. You have to think lungs first.
That distinction is so critical. Okay, let's dive into those 2015 guideline changes. They really shifted the whole paradigm, putting a massive focus on compressions.
They did. And the single biggest change was that confirmed switch from ABC to CAB.
From airway, breathing, compressions to compressions, airway, breathing.
Right. The data just showed that the delay caused by checking the airway, giving those first breaths, it was just too long, especially for people who were hesitant or untrained. It was delaying blood flow.
And part of that hesitation, I remember, was confusion over a specific kind of breathing?
Yes. Agonal breathing. Rescuers were getting confused by it. It's this gasping, noisy, irregular pattern right after the heart stops.
So it's not real breathing?
Not at all. It's a sign of brainstem distress, not oxygen getting in. So with CAB, the rule became simple. If they're unresponsive and not breathing normally, even if they're gasping, you just start compressions.
Yeah.
Immediately.
Let's nail down the new numbers for those compressions, the rate and the depth.
Precision is everything here. The target rate is now a firm 100 to 120 compressions per minute. That's the sweet spot.
Not just at least 100 anymore.
No, a defined range. Fast enough to build up pressure, but not so fast that your technique falls apart. And for depth in adults, it's 2 to 2.4 inches, or 5 to 6 centimeters.
And that upper limit, the 2.4 inches, is just as important.
Incredibly important. The research found that pushing deeper than that dramatically increased the risk of serious injuries. Rib fractures, organ damage. You're trying to save a life, not cause unnecessary harm.
So pushing too hard is now officially poor quality CPR? And what about checking for breathing? The old look, listen, and feel is gone.
It's gone. If they're unresponsive, not breathing normally, you just move. You check for a pulse-carotid pulse in an adult for no more than 10 seconds.
10 seconds maximum.
Maximum. And if you don't feel one, or if you're even a little unsure, you assume there's no pulse, and you start the CAB sequence. Delaying CPR is the worst thing you can do.
Okay, let's put this into action. Section 2. Adult BLS and the mechanics of what you called high-quality CPR. What are the pillars of that?
There are 4. First, hard and fast compressions, hitting that rate and depth. Second, allowing for complete chest recoil after every single push.
Letting the chest come all the way back up.
Yes, so the heart can refill with blood. Third, minimizing interruptions. Hands-off time should be under 10 seconds. And fourth, avoiding overventilation, which we can get into.
So I've assessed the scene. They have no pulse. I've called for help. I'm alone. What's that first cycle look like?
You start compressions right away. The one rescuer ratio is 30 compressions to 2 breaths, and that's for every age group.
30 to 2 no matter what.
Correct. For a single rescuer, your technique is key. Kneel close, heel of one hand on the lower half of the sternum, other hand on top, arms straight, use your body weight, and count aloud.
And when it's time for those 2 breaths, the standard is the head tilt chin lift. But what if you suspect a neck injury? Maybe they fell from a ladder.
Great question. In that case, you have to avoid moving the neck. So you'd use the jaw thrust maneuver. You place your fingers under the angles of their jaw and lift it forward. It opens the airway without tilting the head back. It definitely takes some practice.
And once the airway is open, it's 2 breaths, each for 1 full second, just enough to see the chest rise.
Exactly. And again, no overventilation. Blowing too hard just forces air into the stomach. That can make them vomit, which is a huge risk for aspiration.
A disaster. Okay, now a second rescuer arrives. We switch to 2 rescuer CPR. The ratio for adults is still 30.2, but the dynamic changes.
It changes to maximize quality. One person does compressions and counts aloud. The second manages the airway and gives the breaths. And this is critical, they must switch roles every 5 cycles.
Which is about every 2 minutes.
Roughly, yes.
Yep.
It prevents fatigue and keeps the compressions strong and deep. And that switch has to be fast. Less than 5 seconds if you can manage it.
The handbook also gets into equipment like bag masks. You mentioned the seal is everything.
It is. With a bag mask, it's really a 2-person job to do it right. One person uses the EC clamp technique. Thumb and index finger make a C over the mask to seal it, and the other 3 fingers make an E to lift the jaw.
While the second person squeezes the bag.
Correct. It's almost impossible for one person to maintain that perfect seal and hold the airway open at the same time.
That talk of a perfect seal is a great transition to Section 3. The AED, the Automated External Defibrillator. What exactly is it treating?
So the AED is designed for one specific lethal rhythm, ventricular fibrillation, or VFib.
VFib.
It's just electrical chaos. The heart's ventricles are just quivering, not pumping blood. The shock from the AED isn't meant to restart a flatline heart. It's designed to stop that chaos, to hit a reset button, allowing the heart's own natural pacemaker a chance to take over again.
And speed is everything.
Every minute that goes by, the chance of a successful shock drops significantly.
Okay, before we even put the pads on, what are the absolute must-do safety checks?
First, the person has to be dry, not in a puddle of water. Snow is generally okay, but they can't be soaking wet.
What about things on the chest?
You have to remove any medication patches, like a nicotine or nitro patch. The shock can cause a burn underneath it. And you need to look for a bulge under the skin, which could be a pacemaker or an implanted defibrillator.
And you have to avoid putting the pad on top of that.
Yes. Place the pad at least an inch away from the device.
Okay, walk me through the steps. I got the AED.
First, power it on. Second, bare the chest, wipe it dry. Third, apply the pads, one on the upper right chest, the other on the lower left side under the armpit.
The pictures on the pads usually show you.
They do. Fourth, plug in the connectors. Fifth, stop CPR and you have to loudly announce clear to make sure no one is touching the person. The machine then analyzes the rhythm.
And if it says shock advised?
You announce clear. Again, you visually check that everyone is clear, and then you press the shock button. And here's the most important part. After the shock is delivered, you immediately resume CPR for 2 full minutes.
Without checking for a pulse.
Without checking anything, you go straight back to compressions. That post-shock blood flow is vital for the heart muscle.
Immediate resumption. Got it. Okay, Section 4. This is where we get into the big differences for pediatric BLS. Back to that idea that it starts with breathing.
Precisely. And the procedures change quite a bit. Let's start with the compression ratio. If you're alone, it's still 30.2. But if you have 2 rescuers on a child or an infant, the ratio changes to 15 compressions to 2 breaths.
15 to 2, why the change?
Because the problem is almost always respiratory. They need more oxygen. The 15.2 ratio doubles the frequency of rescue breaths compared to the 30.2 adult standard. It's all about ventilation for kids.
And there's another big change if you find a child who has collapsed and you're alone.
Yes, if it's an unwitnessed arrest and you're by yourself, you do 2 minutes of CPR first before you leave to call for help or get an AED.
Why?
Because there's a good chance that those 2 minutes of CPR alone might be enough to fix the underlying respiratory problem and bring them back. You give them that chance first.
Let's talk technique. Depth is different, obviously.
We aim for about 1/3 the depth of the chest. For an infant, that's usually about 1.5 inches. For a child, maybe up to 2 inches. And the pulse check location is different for infants.
Not the neck.
No, you check the brachial artery on the inside of the upper arm between the elbow and shoulder.
There's also a very specific rule about heart rate in kids.
Critical one. If the child has a pulse, but that pulse is less than 60 beats per minute, you start CPR anyway.
Even with a pulse.
Yes. A rate that low on a child or infant is not enough to perfuse their organs. It means they're about to arrest, so you have to support their circulation with compressions.
And the hand position for infant compressions.
If you're alone, you use the two-finger technique on the sternum. But if there are two rescuers, the preferred method is the two thumb-encircling hands technique. It gives you better, deeper compressions.
And quickly, what about an AED for a child?
You should always use pediatric pads if they're available for a child under 8. They reduce the shock's energy. If you only have adult pads, you can use them. Just make sure they don't touch. You might have to put one on the front and one on the back.
Okay, that makes sense. Let's move to our last section, Section 5, on airway management. What about someone who has a pulse but isn't breathing? Respiratory arrest.
Right, so this isn't CPR, it's just rescue breathing. The rates are different. For an adult, you give 1 breath every 5 to 6 seconds. For a child or infant, it's a little faster. 1 breath every 3 to 5 seconds.
And still, just gentle breaths.
Just enough to see the chest rise. You absolutely have to avoid that gastric distension we talked about.
Okay, let's finish with choking. For an adult, if they can cough, we just encourage them. But if it's severe, they can't speak, they're grabbing their throat.
You go straight to abdominal thrusts, the Heimlich maneuver, get behind them, make a fist above the navel, and give sharp upward thrusts until the object comes out or they become unresponsive.
And if they do go unresponsive,
you immediately start BLS, starting with chest compressions. The compressions might actually dislodge the object.
And for an infant, it's a completely different method, no Heimlich.
Never. For an infant, you use a sequence of 5 back blows followed by 5 chest thrusts.
How does that work?
You lay the infant face down on your forearm with their head lower than their chest and give 5 firm blows between the shoulder blades. Then you flip them over and give 5 chest thrusts, like mini CPR compressions. And you just repeat that 5 and 5 cycle.
And for any choking victim, there's that one big warning.
Right. Never perform a blind finger sweep. You only try to pull an object out if you can actually see it and grab it easily. Poking around in there can just push it deeper.
This has been an incredibly detailed breakdown. Let's try to reinforce one of those key distinctions with a review question. So the question is, the compression to ventilation ratio for 2 rescuer CPR in an infant is 30.2 or 15.2.
And since we know that for 2 rescuers, pediatrics is all about ventilation, the answer is 15.2. To sum it all up, I think successful BLS really comes down to 2 things. First, recognizing the likely cause, cardiac in adults, respiratory in kids, to get your sequence right.
And
second, just universally maintaining those high-quality compressions, that strict 100-120 rate, the 2.4-inch depth, and full chest recoil. Those are the actions that truly sustain life.
This is such vital information. And, thinking about professional responsibility, the source material actually points to resources like Medicode for algorithms and CertAlert Plus for keeping track of your licenses. Which brings us to our final thought for you to consider today. BLS guidelines aren't set in stone. The science evolves. We see major updates about every 5 years. We've just covered the 2015 changes. So the question is, how often are you proactively reviewing the why behind the current guidelines and consciously practicing these skills to make sure your muscle memory is actually high quality when it's not a drill?
That's a critical question.
Yeah.
You have to stay current, be prepared to act, and to act correctly when every second matters.
Thank you for sharing your source material for this deep dive into BLS. Stay safe and stay informed.